Hello, everyone. I'm Dr. Carmen Puliafito, and welcome to Retina Synthesis. Today we have Dr. Arghavan Almony from Carolina Eye Associates. Welcome to Retina Synthesis.
Thank you so much. Thank you for the invitation, Carmen.
You wrote a wonderful monograph on biosimilars in retina for retinal physician. And tonight I'd like to discuss biosimilars with you. Can you describe what a biosimilar drug is?
Sure. This is a really hot topic right now. Biosimilars were first introduced in 2015 when the FDA approved filgrastim. It's a biosimilar for Neupogen. So it started in the oncology realm. And since then, there have been 40 biosimilars that have been FDA approved. And currently, we have access to about 25 of them in medicine. Now, while oncology and rheumatology were the first to explore biosimilars, ophthalmologists were really not familiar with this term and these medications until 2022. This is when we had the first biosimilars approved and launched to market. These were Biosimilar and Cimerli. So they are called biosimilars, and these two are biosimilars to ranibizumab. Biosimilar is approved for macular degeneration, for edema related to retinal vein occlusion, and for myopic CNVM. Cimerli is approved for these three indications in addition to diabetic macular edema and diabetic retinopathy. So when we say a biosimilar, we're talking about a molecule that is highly similar to the reference biologic, in this case, ranibizumab. It's important to understand that when we talk about a biosimilar, we're not referring to a generic drug. We have a lot of different drugs as physicians that we have access to. So for example, when we look at a simple chemical compound like aspirin, if a company wants to make a generic, they can simply duplicate that chemical structure and we have a generic. But when we look at these anti-VEGF agents that we use in retina, these are monoclonal antibodies that are produced from living cells. When you want to replicate that, you can't simply replicate that because they are living organisms that are producing these. And often the manufacturers don't have access to the original cell line that created this. So they have to reverse engineer and produce this from living cells, which are similar to what the original reference biologic is. So they are thought to be highly similar, but not exactly the same.
So they're not identical.
Exactly.
Yes. How do they evaluate biosimilars?
Well, the FDA has a rigorous process through which these biosimilars have to show efficacy, safety, and in some cases, immunogenicity. But in the case of biosimilars versus reference biologics, typically the requirements for clinical trials are much less than the original drug. So these biosimilars go through a clinical trial process. They have to show that they can be used as this molecule, but the clinical trials don't have to have the same numbers. Also, extrapolation is used in these approval process because as you know, the eye is thought to be classically immune privileged. And so when it comes to FDA approval of biosimilars for intravitreal injections, we know that because the eye is immune privileged, we often think that maybe immune reactions and inflammation do not occur in the eye as frequently as they might occur in the body itself. So because of this, the FDA did not require switching studies, meaning studies where the reference biologic, ranibizumab, was used, switched with the biosimilar, then possibly again switched with the ranibizumab, and then switched to show that there were no immunogenicity issues. But the FDA did not feel that that was required for these intravitreal injections. As you know, the issue with that for a lot of retina specialists is we have the recent memories of in 2015, for example, where the first biosimilar was approved in India, and this was Razimab. There were some very significant cases of sterile endophthalmitis that occurred with several batches of that. It was found out to be related to endotoxins in the buffer used in the manufacturing, and this was later filtered out. But that was our first experience, not personal experience, but as retina specialists in the US looking at biosimilars that were being used in India. That issue was fixed because of the filtration process. Then, there was a lot of excitement about brolucizumab more recently. And again, there were issues with intraocular inflammation. There were issues leading to vasculitis and vascular occlusion. And then of course, abicipar, which was not approved because of the intraocular inflammation. So even though we think of the eye as immune privileged, even though the rates of the ocular inflammation are thought to be less than other systemic drugs, we've seen that, and that's very top of mind, I think, for a lot of retina specialists who are considering whether to use a biosimilar.
What's the safety profile of these two biosimilars that are available?
From the clinical trials, we know that these safety profiles are very good. But again, as you know, we have to see what happens in real world usage. A lot of times we've had clinical trials that have been very positive and overwhelmingly brought a lot of excitement to the retina community. But once it starts being used in the real world, that's when we know what's really going to happen with these drugs. And so I would say that with the launch in 2022, we really haven't had enough usage of these drugs to know real world safety profiles.
What percentage of the marketplace is biosimilars? Do we know?
We don't know that yet. Part of it is that the usage is still quite low, and of course that information is not released at this point. But I think what we have to think about is there have been some surveys that they've had small numbers of retina specialists, maybe 100, maybe 60, maybe 75. But this gives us a glimpse as to usage in the retina community. So in these surveys, about half of retina specialists were concerned about safety, about half were concerned about payer coverage. There's also the issues of administrative barriers. So when we look at how much administrative staffing and support goes into the current medications that we're using, if we're adding 2 more drugs to that just compounds it. And the least of which is our fridge space, right? Because we have more and more drugs that we're storing in our offices. There's about 56% of retina specialists in various surveys that have said they really have no knowledge of these clinical trials for the biosimilars, and they don't really understand how the clinical trials were done. Another, I'd say about 50% of respondents to these surveys felt that their concerns were related to the number of patients in these clinical trials. Something that is allowed for biosimilars versus an original reference drug is that when a biosimilar is shown to go through the rigors of FDA approval for one indication, an extrapolation occurs where they are allowed to be indicated for other uses that biologic drug is used for. So if ranibizumab is used for macular degeneration, macular edema due to RVO, diabetic macular edema, myopic CNVM, diabetic retinopathy, the clinical trials only have to show safety and efficacy for one of those indications, and then there's an extrapolation that occurs that allows usage for all of those.
So there are a large number of options. We have faricimab, aflibercept, Avastin, ranibizumab. How's an ophthalmologist to select the right agent for the right patient?
I know. I think that's a very good question. We are very fortunate to have all of these medications, and as we practice and we have the experience of treating our patients, we find that often we're individualizing the treatment regimens to each patient. So there are drugs that work better for one patient. There are treatment regimens and dosing that work better for one patient over another. And so when it comes to the choice of medication, I think it's important to keep that choice to the physician. Unfortunately, one of the big benefits that is shared about biosimilars is access to medication. In fact, there are statistics saying that biosimilars will increase access to more than 1 million patients by 2025. And that number is incredible. But when we think about retina practice, I think it's a little bit different. Our patients are incredibly fortunate, and as physicians treating these patients, we're incredibly fortunate to have programs like the copay programs and the patient access programs, which help patients so that they don't have to worry about the cost of these medications when they're trying to decide whether they can afford to save their vision. But the issue is that in retina, our patients already have access to these great medications and a wide variety of them. But when it comes to access, the only time that me or my retina colleagues that I speak with, access is only an issue when payers, insurance companies, limit that access by, forcing step therapy or forcing one medication over another. Not because the patients don't already have access to these medications. I understand this is not the case in other countries, and we're very fortunate in the United States to have these programs. But I think for our patients in the United States, they already have access. And like you said, we have great drugs. When we think about Lucentis and Eylea, we've had those for a long time, and we have a lot of experience with those. But now we have faricimab, Vabysmo, which is available. This is a dual pathway inhibition, which has shown great promise. And the clinical trials showed that patients can go up to 16 weeks between injections. That's incredible. That's almost 4 months. We have, Susvimo, which is currently not on the market, but again, it's a new platform that allows certain patients who are good candidates the ability to possibly go 6 months between injections. We also have coming on the horizon things like high dose Eylea, again going possibly up to 16 weeks between injections. And so because we have these amazing things coming down the pipeline and already here, we don't necessarily have to depend on biosimilars. We have better treatments already available. The other factor that we have in retina that maybe is not as prominent in oncology or rheumatology, where these biosimilars have become more at the forefront, is we have Avastin, which, yes, it is not FDA approved and it, is compounded, but we have almost 2 decades of experience with bevacizumab. And we know that it works. The CAT trial has showed that it works, and we know that it's safe. So there's a lot of competition for biosimilars. When a physician is deciding whether to switch or not, I think there has to be really good data. Retina specialists are a small community. They look for peer-reviewed data and they talk to their colleagues. And because of that, there has to be a really good reason to switch to a biosimilar when we have all of this experience already with other medications, and now we have new drugs available and others coming down the pipeline.
Do you think they're going to add biosimilars to the step therapy algorithm?
They already have. Yeah.
Is it widely used? So in other words, it's Avastin 1, biosimilar 2,
Correct.
and a branded product, another branded product after that?
Correct. And sometimes that branded product is also forced, and the physician does not have choice. So, it just depends on the payer. There's some payers that are much more aggressive dictating these things. There's other payers who still believe in physician choice and they allow what's best for patients.
So there are economic incentives that have been presented to retina specialists to use biosimilars. Can you comment on that?
Sure. The main economic incentive is that typically these drugs receive a ASP plus 6% for reimbursement. And with the biosimilars, a ASP plus 8% has been approved. So when a biosimilar is used, physicians are getting an additional 2%. The question is, why are we making this an economic choice? Why is there not data showing us that biosimilars are equally good or better so that we can depend on that data and do what's best for patients rather than giving a 2% incentive to physicians? I think most physicians go into medicine because they want to, as idealistic as it sounds, they want to help people, they want to take care of people. And so I think that the data-driven decisions allow physicians to sleep better at night than the financial incentives.
So what is the base price of the biosimilars compared to Eylea or Lucentis?
There's about a 10 to 20% saving. So there are some biosimilars in medicine that have up to 40%. And in fact, when Bioviz and Cimerli were coming out, there was predictions that there may be a 40% discount on these biosimilars. It's ending up to be about 10 to 20%. And, again, they are competing with bevacizumab, which is much cheaper and has about 2 decades of experience. There are some predictions that there may be, things coming on the market where they are a reference drug like bevacizumab, where maybe bevacizumab compounded would not be available anymore. If that happens, that'll change what happens with biosimilars, I think. But at this point, we still have access to Avastin, and even though it's off-label, we know that it works and we know that it's safe.
Do the biosimilar companies offer co-insurance, co-pay programs?
They do. So these copay assistance programs and patient access programs for biosimilars are similar to what is happening with the reference drugs, ranibizumab, Eylea, faricimab. So very similar. So, in both cases, patients are being taken care of. Patients aren't having to choose between eating dinner and paying for a drug, or buying their other medications and paying for a drug, which sometimes happens in the medical world.
What are the expectations about a biosimilar to aflibercept?
There's a lot coming down the pipeline. So aflibercept runs out this year, and the patent runs out this year, and so there are about 7 or 8 different aflibercept biosimilars coming down the pipeline. Aflibercept has a larger share of the market for macular degeneration and diabetic macular edema, so there are some thoughts that may also change the retina market for these. But at this point, I think physicians are still looking for more information, more education about biosimilars, and they're looking to see what happens with real world usage.
So do you have any final words about the forecast for biosimilars going forward?
I think it will depend a lot on what we see in the real world. There have been drugs in just the last few years that there's been a lot of excitement about, but in the real world, it didn't pan out. And so I think that we'll have to see, once a sufficient number of patients have been treated with these biosimilars, if we're seeing good safety, good efficacy, good payer coverage, which that's how physicians can run their businesses. So I think those factors are all important. I think that looking at the oncology and rheumatology landscapes, I think biosimilars will be a part of the retina landscape, and I think that's a good thing. The more options we have in our toolbox, the better for patients. But I hope that it doesn't become a situation where the physician choice is taken away for what drug is best for our patients.
Well, Arghavan, this has been a really wonderful discussion about a topic that has generated lots of interest, but as you said, 56% of retina specialists really felt they didn't know enough about it. This will help.
Thank you so much for having me. I appreciate it.